It's an oft-used statement that it's a great privilege to introduce the speaker, but it sure applies to Dr. Moore today. Dr. Moore has been one of the pioneers in vascular surgery for many, many years. As past president of almost every important society that we have, and is the editor-in-chief of Endovascular Surgery. But I really first was aware of him in particular when EVT endografts, the first aortic endografts really were brought in the country, and he really was one of the principal investigators. I think he may even have done the first case in the United States. More recently, his legacy has been his interest in carotid disease, and he has been the principal investigator in many of these large national trials. And as you're going to see, he's gotten tremendous experience around Crest. He's particularly now interested in the new flow reversal systems, and I'm sure he's going to address that. But what will come out of this is his very thoughtful, methodical, and quantitative approach to analyze and trial data. That's what he's particularly known for. And I think he can take you along in convincing you using that data. He's a tough guy to argue with because he's always got that data really at his fingertips. But you'll see he's not just a die-hard vascular surgeon that's all about cutting. He's always been regarded as he's a preeminent technical open vascular surgeon, but has also been a pioneer and on the leading edge basically of looking at new minimally invasive endovascular techniques. So there's really not anybody in the country who's better at addressing the controversy of carotid endarterectomy versus carotid stenting. And so he's going to give us the data on the current status basically of the controversy. Well, it's a real pleasure to host you here in Houston. Thank you very much.
Dr. Lumsden, thanks very much. It's a pleasure to join you here in Houston, and I thank you for the honor of invitation to be able to talk about this particular topic. I realize that we have multiple specialties represented in the audience today, and I hope what I have to say will not offend some of my interventional colleagues because I consider myself an interventionist as well as a surgeon. Fortunately, this topic has become fairly mature over the several years, and we have a number of prospective randomized trials that we could look at to get some data. And I'm going to go over three of these trials, specifically the French trial, the international trial, and the Crest trial. The first trial to report was the EVA-3S, or the French trial, which was a prospective randomized trial comparing carotid endarterectomy with carotid artery stenting in average risk symptomatic patients. And that trial actually was stopped before it went on to completion, and the reason for that was that the Interventional Management Committee saw a 3.9% death and stroke rate with carotid endarterectomy. Contrast that to a 9.6% death and stroke rate with carotid artery stenting, and that difference was highly statistically significant, and therefore the monitoring committee felt justified in stopping the trial. This was picked up by the media the very next day after the publication in the New England Journal, and this was the headline in the LA Times, which came to the conclusion that stents were too risky for stroke prevention. The next trial that I'd like to talk about was the large international trial, which basically did the same thing, was a prospective randomized trial comparing carotid endarterectomy with carotid artery stenting in average risk symptomatic patients. It utilized the talents from 50 academic medical centers in Europe, Australia, New Zealand, and Canada, and the primary endpoint was a 120-day interim analysis, including primarily death and stroke, but also procedure-related myocardial infarction. And this is the table from the Lancet article, which I'm sure you can't see in the back of the room, but let me just bring out the top line for you for a moment. And we're looking at the stroke death and MI rate in the stenting group of 8.5% versus 5.2% in the endarterectomy group. It had a very robust hazard ratio of 1.69 and a p-value of 0.006 in favor of endarterectomy over stenting. And here's the Kaplan-Meier presentation. This is all stroke death MI, showing the high rate in stenting, the lower rate in endarterectomy. This is any stroke, and again you can see the difference. Any stroke and death, any disabling stroke and death. And no matter how they sliced and diced it, endarterectomy came out ahead of the group. As a part of this publication in The Lancet, they also did a meta-analysis of all three of the trials. Crest had not yet reported. And in this whisker plot diagram, anything to the right of the median indicates favoring endarterectomy, anything to the left favored stenting, and that this is the overall meta-analysis showing an odds ratio of 1.73 in favor of carotid endarterectomy. Now, the investigators also did something else that was particularly important, and that is that they identified a group of patients in whom they would do pre-procedure MR scanning and post-procedure MR scanning to look at the incidence of new areas of cerebral infarction, whether they be overt or silent. And here is the table from that Lancet article, and just to bring out the top line figure, at least one new lesion following procedure. 50% of the patients undergoing carotid stenting had a new lesion, compared to 17% undergoing carotid endarterectomy, and that was a very robust odds ratio and a highly statistically significant p-value favoring carotid endarterectomy. They also did a meta-analysis on other trials that have done a similar analysis. And again, this is the meta-analysis figure with an odds ratio robustly in favor of carotid endarterectomy. So now we get on to the Crest trial. And the Crest trial had several unique features. Specifically, there was a lead-in phase for the carotid angioplasty group, recognizing the carotid angioplasty was a relatively new technology at the time, and the need to make sure that everybody was up to speed before they actually started entering cases in the randomized trial. So there was specific training for the interventionists using the AccuLink, AccuNet systems, and each interventionist had to submit up to 20 lead-in cases demonstrating that they were able to do this procedure with technical competence and safety. The primary endpoint was a composite, and the composite consisted of stroke, myocardial infarction, and death, or periprocedural, for periprocedural, or ipsilateral stroke after 30 days. And the results were reported in the New England Journal several years ago. Tom Brott was the lead author. Bob Hobson, who actually started the trial, sadly passed away during the course of the trial. The final randomization was 2,500 patients with a median follow-up of 2.5 years in that initial publication. And the top line number, that is the composite endpoint, death, stroke, and myocardial infarction, 4.9% with carotid endarterectomy, 5.9% with carotid artery and stenting. That difference was not statistically different, and it led to the statement that the two procedures, at least within the Crest trial, were equivalent. At this point, I'd like to point out something for your consideration in what I consider to be a design error when we designed Crest. And I have to take part responsibility because I was there at the time. And my concern is that when you simply add each of the primary endpoints to a composite endpoint, What in fact you're saying is that they're equal. And I don't think anyone would agree that death is equal to stroke is equal to MI. They're all important, but they have different values. And what we should have done was to assign a rating or a ranking for each of those. And so what I did just for fun was to ask myself, how would I go about assigning a point value for each of those events? Well, the first thing we could do would be to ask our patients what was important to them. Obviously, dead patients aren't going to tell us it, but I think I can assume that they weren't too pleased with that outcome. The next of the living patients, the most important feature in this analysis was major stroke. The next most important thing to the patient was minor stroke. And after 1 year, myocardial infarction, at least from the patient's perspective, was not particularly important. So what I did was to arbitrarily assign 10 adverse points to death, 8 adverse points to major stroke, 7 adverse points to minor stroke, and 5 adverse points to myocardial infarction. And this was based basically on the patient's perspective of what the complication meant to them. And so these are the actual numbers from the Crest trial. There were 9 deaths in the angioplasty group, and that led to 90 adverse points. There were 4 deaths in the carotid endarterectomy group, giving us 40 points here. And we went down the line, major stroke, minor stroke, myocardial infarction, and when you added them all up, there were 535 adverse points for CAS, 391 adverse points for CA. That difference numerically was statistically different. And so if we look at the bottom line analysis of Crest and the traditional endpoints that we look at, death and stroke, 2.6% for carotid endarterectomy versus 4.8%, almost double, for angioplasty and stenting. And that difference is statistically significant at the 0.005 level. We also learned a number of other things during the course of the Crest trial, and I'm sure you've all seen this particular table. And contrary to what you might expect, older patients did better with carotid endarterectomy. Younger patients did better with carotid angioplasty and stenting. And the inflection point is around 70 years of age. The other question that needs to be asked is, what's the impact of a higher MI rate with carotid endarterectomy compared with carotid angioplasty? And certainly in other trials, a troponin elevation is associated with a compromise of life expectancy. However, in Crest, the survival, late survival among the CA and CIS patients was virtually identical, and that was due to the surprise finding that stroke, even minor stroke, compromised long-term survival in exactly the same way that myocardial infarction did. So the four-year mortality rate comparing patients with and without stroke or with and without MI is as follows. If the patient had an MI, the 4-year mortality rate was 19% versus 6.7% in those that didn't have an MI. And if they had a stroke, there was a 20% 4-year mortality compared to 11.6% in those that did not have a stroke. So the survival benefit of a lower MI rate with CAS is offset by the higher stroke rate in CAS. And the higher stroke rate with CAS places the patient at the disability not only because of the late mortality rate, but also because of the disabling effects of the stroke itself. So we might ask, why was there a higher MI rate with carotid endarterectomy compared with CAS? And remember that at the time that the Crest trial was designed, statins didn't exist, and we didn't recognize the value of using beta blockers in patients with coronary artery disease. One other possibility that we might consider is that all of the CAS patients were on dual antiplatelet therapy, both aspirin and Plavix, versus the carotid endarterectomy patients who were on aspirin alone. And that may or may not have had some impact in terms of protection against myocardial infarction. The other thing that we learned in Crest was that gender mattered. And here we are looking at a Kaplan-Meier curve on the ordinate or the stroke morbidity and mortality rates. And this particular line represents women undergoing carotid artery stenting versus women undergoing carotid endarterectomy. And so women tend to be at a disadvantage, at least in Crest, when they underwent carotid angioplasty and stenting, but were not at a disadvantage when they had carotid endarterectomy. So another thing that we need to look at is the interventionist approval process. 427 interventionists applied for participation in the Crest trial. Only 227, or about half, were able to jump through all the hoops and were approved to participate. And so the question is this very selected group of interventionists representative of the community at large? And can the very good results with CAS in Crest be reproduced once it's adopted worldwide? The other thing that has been alleged as far as angioplasty is concerned is that since this was relatively new technology, maybe people got better as the course of the study went along. So we decided to ask that question and specifically looked at to see whether there was a temporal relationship between the event rates with carotid angioplasty and stenting. And this was published recently in Stroke. And if you look at the unadjusted event rates, specifically death and stroke, in the first period, that is right at the very beginning of the trial, it was 6.2%. In the middle period, it was 4.9%. In the third period, it was 4.6%. And so there certainly seemed to be a trend showing an improved safety record, but those differences were not statistically different. Now, one of the other things you have to ask was there any change in the composition of patients that were being entered into the Crest trial during the course of the trial? And the answer was there certainly were. As the trial progressed, fewer women were entered into the trial, and again, as I've pointed out, that happened to be a high-risk group for CAS. Fewer octogenarians were entered into the trial, again, a high-risk group for CAS, and more asymptomatic patients were entered, again, the safest group to either operate on or to stent. And so if we adjust for those three variables, what we find was that in the first period, the event rate 6% for CAS, second period 5.9%, third period is 5.6%. No change during the course of the trial. Therefore, what we can say is that the people that were doing carotid angioplasty and stenting in Crest really hit the road running and were pretty much up to speed as far as their technical competence was concerned. One of the other areas that we decided to look at was actually the angiographic characteristics of the plaque that was being treated as to whether or not there might be a difference between certain angiographic characteristics of the plaque in carotid endarterectomy versus carotid angioplasty and stenting. And this was recently published in JVS, and I can share with you what our findings were. So the question that we asked was, are age and gender really surrogates for angiographic plaque characteristics that represented high risk for CAS, but not necessarily high risk for CEA. So we took a look at the plaque characteristics as possible result modifiers, and we used a logistic regression model to compare the results with CEA and with CAS. And what we found was that there was an increased risk of stroke and death with CAS compared to CA in the following three instances. If the patient had a long lesion, and by long, the median length of the lesion angiographically was 12.85 millimeters, so anything longer than the median was considered to be long. If the lesion was dysynchronous or sequential, or if the lesions were distal to the carotid bulb, all three of these were found to put CAS at a disadvantage compared with carotid endarterectomy. And here's what we found. If the patients had a long lesion, the event rate for carotid endarterectomy, 1.9%, versus the event rate of 6.1% for CAS. If the lesion was sequential, 0.7% for endarterectomy, 5.8% for CAS. If the lesions were remote, 1.6% for endarterectomy, 5.2% for CAS. So at this point, we can now begin to populate a list of lesions that are high risk for CAS, and perhaps give us a better opportunity to select the patients that we want to do CAS versus endarterectomy. And so the first item from Crest is a long lesion. Next is a sequential lesion. Next are distal lesions. From other publications, we also know that a type 3 aortic arch puts patients at a disadvantage for CAS, as does an atherosclerotic aortic arch, as does tortuosity of the internal carotid artery, as does circumferential calcification, as do ulcerative lesions. And the only thing that's a little bit disconcerting is that these first three items from Crest represented 2/3 of the patient population in the Crest trial. So if, in fact, these were to be considered exclusions for carotid angioplasty and stenting, only about 1/3 of the patients would then qualify as being safe for transfemoral angioplasty. The other thing that we've noted in all of the trials is that the event rate for CAS is front-loaded. That is, it occurs within the first day or two, or certainly within the first 30 days of the procedure. And that's best shown in the EVA 3S trial, where you can see the discrepancy between the high rate of angioplasty and stenting versus endarterectomy. But once you get past the first 30 days, these curves are completely parallel. And so once you've gotten by the procedure, the results of angioplasty and stenting and endarterectomy in terms of stroke prevention and durability are really equal. This was also seen, we just reported the 10-year data from Crest, and again you can see the same phenomenon. The hit that CAS takes is right here, and then these two curves remain parallel. And so what are the potential causes for paraprocedural events in transfemoral CAS? Well, we've already talked about it, and that includes a diseased aortic arch, type 3 aortic arch, and if you're using a distal protection device, you have to traverse the lesion before you get the protection device in place, and the traversing of the lesion may very well cause a release of embolic debris. And so, obviously, patients that have atherosclerotic changes within the arch are a problem. And in fact, within the Crest trial and in most trials, not all of the periprocedural strokes are ipsilateral to the side of the stenting. So on your way there, or while you've got residence time of the guide wire and catheter, you may very well be knocking off bits and pieces going up the side opposite that you're treating. And obviously, traversing the lesion itself in order to get a distal protection device in place can be a problem. So in 2004, there were two seminal publications that looked at an alternative way of doing CAS. And that is, rather than going transfemoral up through the arch, selecting the vessel that you want using a distal protection device, what the investigators did was to say, maybe why not just go directly to the carotid artery itself to do CAS, therefore avoiding the aortic arch and its consequences. And while you're there, instead of placing a distal protection device, what you can do is actually clamp the carotid artery and allow flow reversal from the carotid artery to either a jugular vein or a femoral vein, the opportunity to carry away any embolic debris and avoid the possibility of distal embolization. So this was the first paper that was presented by Chang and colleagues from Northern California. And what they did was they took 21 patients with carotid stenosis. They had sort of a homemade device, used available sheaths to put in the carotid artery, got some tubing, connected it to a sheath in the femoral vein, and by clamping the carotid artery and taking advantage of the pressure gradient between the carotid artery and the femoral vein, allowed for flow reversal. What they were able to do is to carry out stent angioplasty with 100% technical success rate and no deaths and no strokes. The second paper that same year was published by Enrique Criado and his colleagues at the time that he was at Stony Brook in New York. And in their group, they had 50 patients. Again, a short supraclavicular cut down to expose the common carotid artery, again using a homemade device for access and flow reversal. Again, 100% technical success rate, no deaths, no strokes, and a 98% one-year patency rate of the stented artery. So along comes industry to now give us a device that is specific for this procedure. And this is the Silk Road sheath that goes in the common carotid artery. And there's a little flow stop here, so you can't push the sheath in too far. And what you're doing is with the sheath in the carotid artery and the carotid artery clamped, and with the sidearm carrying blood from the carotid artery to the femoral vein, diagrammatically you see all these particles going south instead of north. And so here diagrammatically is the Silk Road system with the sheath in the carotid artery, the sidearm going to a flow regulator, and then blood being returned to the femoral vein. Within the flow regulator is also a filter trap to capture any embolic debris. The trial that was carried out in the United States was the so-called Roadster trial, in which we entered 141 patients considered high risk for carotid endarterectomy, either because of medical comorbidity or because of anatomic issues. Technical success rate in the U.S. trial, 100%, no major strokes, 2 minor strokes, and 2 deaths. There was 1 temporary cranial nerve injury, but no permanent cranial nerve damage. And so at this point, if we compare the Silk Road data in high-risk patients with the Crest data, which was in average-risk patients, here's the Crest data for carotid angioplasty and stenting with a stroke and death rate of 4.1%. Carotid endarterectomy in Crest, 2.3%. And here we are with the direct carotid stent angioplasty using the Silk Road system of 1.4% in a high-risk group. So in summary, direct carotid stent angioplasty with flow reversal has results that are at least comparable and perhaps even better than carotid endarterectomy. And so at this point, ladies and gentlemen, I would conclude that the transfemoral approach to carotid angioplasty and stenting, at least based upon the data that I've shown today, is inferior to carotid endarterectomy. So carotid endarterectomy, when compared with the transfemoral approach, in my opinion, is the procedure of choice for both symptomatic and asymptomatic patients. However, the new direct carotid angioplasty stent approach, that is TCAR, is certainly competitive with and may even be better than carotid endarterectomy. And with that, I'd like to thank you for your attention and happy to answer any questions.